clinical case presentation. Before we start, I request Chairman Dr. Narayan Chandra Hebsur to do the welcome address.
Thank you, Chandru. I really bring a very warm welcome to all of you. Again, we have started this clinical case presentation, and last year we were doing this. Now, this is the first case presentation we are having this year. I welcome you all for this, and I welcome our past president and present governing council, academic council chairman Dr. Siddesh sir, and national EC member and incoming chairman Dr. Rajgopal Shenoy sir, chairman of scientific committee Dr. Kalaivani madam, Dr. Ramakanth, moderator of today, and Dr. Srikanth Kuntoji sir, professor of surgery from Bagalkote. I welcome you all. I request the moderator to please start the session. Dr. Ramakanth, kindly take over and start.
Yes, sir. Thank you very much, sir. Today we are having a case presentation by postgraduate Dr. Priyatmakumari, Shri B M Patil Medical College, Vijayapura. Now I call Priyatmakumari to proceed with the case.
Before we start, we'll have a brief introduction of Dr. Ramakanth. Dr. Ramakanth is a professor in B M Patil Medical College, Vijayapura. And we have external faculty, Dr. Srikanth Kuntoji, Professor, Department of Surgery, S.Nijalingappa Medical College, Bagalkote. We have Dr. Rajgopal Shenoy sir, Professor, Department of General Surgery, Kasturba Medical College, Manipal. And Dr. Kalaivani V, Professor, Department of General Surgery, Sapthagiri Institute of Medical Science, Bengaluru. And we have a presenter, Dr. Priyatmakumari, resident, junior resident in Department of Surgery. You can start your presentation.
Thank you, sir. Good evening, everyone. So today I am here to present a case of a 64-year-old female. She is a homemaker by occupation and she is a resident of Vijayapura. She came to us with the complaints of pain in the abdomen since 1 month and mass in the upper abdomen since 20 days. Coming to the history of presenting illness, so patient was apparently all right 1 month back. Then she developed pain in the abdomen, which was insidious in onset and non-progressive, with occasional exacerbation, a dull aching type of pain, non-radiating, mild in intensity, no aggravating factor, but it relieved on medication. She was investigated for the abdominal pain and was informed that she has a mass in the upper abdomen 20 days ago, which brought her to our hospital. The mass was insidious in onset and has not progressed in size since she was aware of the mass. So there is no history of vomiting, hematemesis, early satiety or fullness, heartburn or regurgitation of food, yellowish discoloration of sclera or skin, loss of weight or loss of appetite, melena, altered bladder or bowel habits, or chronic drug intake. Coming to the past history, she is a known case of hypertension since 1 week and she is on tablet telmisartan 40 mg once in a day. There is no history of any other comorbidities and there is no history of any surgical intervention. Personal history, patient takes mixed type of diet with normal sleep, her appetite is normal. She has a regular bladder and bowel movements and has no habits. She attended menopause 8 years ago and she has 3 children. Family history, nothing significant. So coming to the summary, a 64-year-old female with complaints of pain in the abdomen since 1 month, which was insidious in onset, non-progressive, continuous, dull aching type of pain, non-radiating, which relieves on medication. She also complains of mass in the upper abdomen since 20 days, which was detected during investigations and recently diagnosed hypertension with no other comorbidities and undergoing surgical intervention. There is no history of, there is no significant family histories.
Can we stop here, sir? Shenoy, sir?
Yes.
What do you mean by non-progressive pain?
Sir, pain was just dull aching type of pain, sir. It was like
suspected ಅಂತ ಕೊಟ್ಟಿದ್ದಾರೆ. Dr. Siddesh, okay. Yeah. Go ahead, Dr. Priyatam.
So, pain was just dull aching type. Continuously, it was vaguely present, sir. It was not.
Priyatama, you are telling pain abdomen, but you are not telling the location of the pain. Where
Sir,
is the
it
pain
was
located in the abdomen?
mostly in the upper abdomen, sir.
But you should tell specifically, no? Your
Mention that.
abdomen
You
is
should
a
mention that.
very large area having 9 quadrants. You are not telling where exactly the pain is appreciated by the patient, where she feels the pain.
Yes, sir. Mostly in the upper abdomen, sir, in epigastric region, sir.
Why it is important to know the location of the pain?
So we can differentiate between whether from which organ anatomically it is coming.
Okay, here she has got, where is the pain located in this patient?
So in the epigastric region, sir.
So can you tell some of the causes patient can have pain in the epigastric region?
First and foremost is gastritis, sir, or any gastric ulcer, or cholecystitis can be a reason.
Cholecystitis presents the pain in the epigastrium or the right
So
hypochondrium?
it presents in the right hypochondrium, sir, but sometimes they come with the complaints in the epigastric region also.
No, but you are telling it is a dull aching pain.
Yes.
Gastritis pain is a dull aching pain. Cholecystitis will have a dull aching pain.
No, sir. In gastritis we have a burning type of pain, sir.
So you are telling dull aching pain located in the epigastric region. What are the causes for dull aching pain in the epigastric region?
Gastritis might be a cause, sir, or
No, acute gastritis or acute gastritis will not give rise to dull aching type of pain. Usually, what is the origin of pain in dull aching type of pain in the abdomen?
so the mucosa, sir.
No. The dull aching type of pain usually comes from the solid organs like liver,
Yes.
okay, pancreas, depending on the pathology.
Yes.
So here, since you are presenting pain in the epigastric region, the probable cause of dull aching pain may be arising from the liver, probably a left lobe of liver in this case, since pain is there in the epigastric region.
Yes.
So what are the other causes?
Dull aching type, sir, or
Here the patient is having dull aching type of pain only.
yes. Maybe any the mass which is causing the pressure, and that is leading to the dull aching type of pains.
So here you're telling it is slow to start, incidences are non-progressive.
Yes.
Are there any aggravating and relieving factors?
So there are no aggravating factor, but sir, but it gets relieved on medications.
What medication?
So you are taking antacids, sir, and with that like analgesics.
Okay. So what are the other organs which can give rise to pain in the epigastrium other than the stomach and the liver?
That can it can be pancreas, sir, or pancreas or omentum, sir, or it can be transverse colon, or it can be retroperitoneum, sir.
Transverse colon usually doesn't cause dull aching type of pain.
Okay, sir initially told that all the pain, dull aching pain is due to solid organs.
Solid organs.
So don't mention, isn't it? So
Yes.
don't mention. It's given you a hint.
Yes.
Okay.
Yes.
Oh, okay. Fine. Now, why did you look for radiation of pain? What did you want to rule out?
Ma'am, I wanted to rule out if any like if it is getting radiated to the back, ma'am, like posterior ulcers, they get radiation to the back, ma'am, or if pain is getting radiated to the tip of the shoulder, ma'am.
Posterior ulcer itself, you mean to say posterior ulcer from the stomach that radiates to the back, or when the ulcer infiltrates some other structure?
Infiltrates in the pancreas, sir.
Pancreas. So is the radiation of pain due to infiltration in the pancreas? So will pancreas cause any radiation of pain, pancreatic pathology?
Ma'am, pancreatic, it radiates to the back, ma'am.
Why?
Retroperitoneum, ma'am.
What structure is there due to infiltration of something? Sir gave you a clue. Infiltration of some structure that causes radiation of pain. See, these are the basic things, okay? So PGs, don't end up missing these basic things. And later you make a diagnosis and then you talk about immunohistochemistry and you talk about treatment strategy and all that. It is without knowing basics, like it's not right, okay? So this basic, it's there in your chronic abdomen chapter in DAS. So please read it up. These are the basic questions. If you don't cross these basics, then it becomes difficult for discussion. Okay, so simple things. Okay, now you said radiation to the tip of the shoulder. That's due to what?
That is a referred pain, ma'am. That cholecystitis.
Referred pain. Yes. What exactly happens? How does it go there?
The phrenic nerve gets irritated, ma'am, because of the inflammation of the gallbladder, and that gets they share the same dermatome, C3, C4, and that causes pain, ma'am.
No,
Because
it's
of
not
the phrenic nerve.
dermatome. It is not the dermatome, Dr. Priyatma. It is the same nerve root of that of phrenic nerve, which supplies the diaphragm, and that of the supraclavicular nerves. Okay, so
Yes,
there's a difference. This is called referred pain.
Yes, ma'am.
Okay, and dermatome pain is the example is the appendicitis, a shifting pain.
Yes, ma'am.
Okay, we are going too much into basics. Sir, Rajgopal sir, next.
So Priyatma, one or two things that dull aching pain means it is a solid organ enlargement and it leads to parietal capsule, which is stretched, which is more sensitive. So
capsule stretch.
Here we should think of mainly liver, okay, and pancreas. Now you have one more point here that patient has a mass, so you should never entertain cholecystitis, gastritis, all these things. Since the patient has been diagnosed as a mass, now you have to correlate and tell us pain and the mass, dull aching pain and the mass in the upper abdomen. So one or two possibilities. What is that come into your mind if you think it is liver? What else you come into your mind if it is pancreas? What else come into your mind if it is retroperitoneal means could be a lymph nodal mass. This is how you should start working on that. Okay. Yes. Just think of one or two things from the liver first so that you rule out quickly.
So in liver, if we go for any hepatic cysts or
possible
hydrated cyst,
possible,
then amoebic cysts that might cause pain. And
is it amoebic cyst or amoebic abscess you're talking about?
So amoebic abscess, but in that case, fever will be there, sir.
So this is what we want you to answer: pain and the mass with no other features. See, your previous slide is everything is negative, 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 negative. Correct? No?
Yes.
So you are trying to rule out one by one. So whether it's fever, whether it's inflammatory or a neoplastic mass. What is the age of the patient?
64-year-old female, sir.
So what is the duration of your symptoms?
So 1 month back, she had pains.
So short duration. Somebody has felt the mass, correct?
Yes.
So what is it likely? More for amoeba, more for hydatid, more for simple cyst, or more for neoplasms at this age?
More for neoplasms at this age.
This is how we should try to argue in the examination. Okay.
Yes.
So if it is, do you think it's stomach? Do you get some dull aching, vague discomfort there? Gastritis. So better not mention gastritis. Can you have stomach masses also? Can you have vague discomfort, pain and the mass? Epigastric mass and the pain, you should consider stomach also.
Yes.
Don't bring gastritis into discussion now. Okay, because the mass there is for us to find out later what is it. Okay?
Yes.
Do you think it could be a carcinoma, say body of the pancreas, large mass there? Do you think it is possibility?
Sir?
Pancreatic mass. Pancreatic mass.
Pancreatic mass can be there, sir. Can be there, sir. Yes,
What kind?
Pseudocyst of pancreas.
From which part of the pancreas you think from the
body of the pancreas. It goes to the.
So you have to think in that direction, and that is how you can proceed with your further presentation. Madam, we can probably go. Sir, moderator, sir, can we proceed, sir? Or you want to tell something? Moderator.
Priyatama, if you think pancreatic body masses, what are the possibilities you think?
So
keep her age in mind. Okay, how old is she?
64-year-old, ma'am.
So you should keep that in mind. Keeping that in mind, you should think what pathology. First is the anatomical organ there. Then next is pathology, correlating with her age and the short symptom.
Yes.
No, for 1 month duration.
Yes, ma'am. Cystadenocarcinoma can be there from body of the pancreas.
Yes.
You don't have to tell the details.
Yes.
Carcinoma of pancreas.
Pancreas, yes.
Because the rest is the pathological diagnosis.
Yes.
The one possibility is carcinoma of the body of the pancreas.
Pancreas.
Can you think of pseudocyst of the pancreas in this patient?
So she doesn't give any history of a previous attack of pain, sir. No history of any acute pancreatitis is there, sir.
Now, how a pseudocyst in a chronic pancreatitis presents? Of course, the history is just a short duration here, just 20 days to 1 month. So how a patient with chronic pancreatitis presents with a mass in the epigastrium?
Sir, they will have pain, sir, and mass will be there. With that, they'll give a history of like chronic pain, and steatorrhea will be there, sir, in case of chronic pancreatitis.
Yeah, you have to rule out that chronic pancreatitis. Patient will have a chronic pain. A patient will have steatorrhea, recent onset of diabetes, malnutrition.
Yes.
And then developing a mass in the abdomen, epigastric region, probably can think of chronic pancreatitis.
Chronic pancreatitis.
Priyatama, can you have any other pancreatic mass which is non-malignant, that can attain a large size, more common in women? Age may be slightly now elder. It is more likely. Any other lesions more common in women? Pancreatic. No, you said cyst. What is that? You said some adenocarcinoma, something you mentioned.
Cystadenocarcinoma.
So cystadenomas.
Cystadenomas. Yes.
The benign conditions.
They attain a very large size. Okay.
Yes.
Patient has felt that mass. Somebody has felt the mass.
Yes.
So this is how we would like to go through the case. Okay. So
yes.
I think we can go ahead. Right.
Thank you. Priyatam, one more question. See, you said there is no hematemesis and melena.
Yes, sir.
So what is there in your mind to ask hematemesis and melena? You think it is a lesion from the stomach only, or you can get hematemesis and melena from any other lesions in the epigastrium?
So because the mass was there in the upper abdomen and it shows like epigastric, that anatomy says most probably it might be arising from the stomach, sir.
No, you don't know. You get the history. You're not examined.
Yes.
You said just upper abdominal mass, the epigastrium.
Yes.
So when do you ask history of hematemesis and melena in epigastric mass? What are the possibilities?
So one is CS stomach, and other we can think of pseudocyst of pancreas also, sir. In pseudocyst of pancreas, splenic vein thrombosis will be there, sir. That might lead to portal hypertension, and that might lead into hematemesis and melena afterwards.
Yes, very good. In a chronic pancreatitis patient developing a pseudocyst, they can have a splenic vein thrombosis causing portal hypertension and leading on to bleeding, variceal bleeding, giving rise to hematemesis and melena, right?
Yes.
That is very important.
Yes.
Apart from carcinoma stomach, you can also think of a mass lesion in the epigastrium arising from the pancreas. Chronic pancreatitis producing a pseudocyst. They can also present with hematemesis. Okay.
Yes. Yes.
You can go for examination, I think so. Go for examination, ma.
Yes. Coming to the general physical examination, elderly female patient, moderately built, nourished, conscious, cooperative, and oriented to time, place, and person. There is no pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. Karnofsky performance scale is 90% and her BMI was 28.3. Pulse was 78 beats per minute, normal in rate, rhythm, character, volume, and condition of the vessel walls were normal. BP was 130 by 80 mmHg on right upper limb in sitting position. Respiratory rate was 16 cycle per minute, and she was afebrile. Coming to the local examination, patient was examined in a well-lit room after taking consent in a supine position with arms kept on sides and adequate exposure.
Please
So
put the
abdomen.
picture, no, Priyatma, put that picture, no, as you are telling the findings.
Yes, ma'am. So
Yeah.
we can abdomen was protuberant, ma'am. We could see a mass in the epigastric fullness was noted, which was seen from below Giphisternum till umbilicus, ma'am, and towards the it was moving felt towards the both bilateral hypochondrium and and lower border were towards the till the umbilicus, which is around 10 into 12 centimeter, ma'am. Then there was umbilicus was inverted and central in position. Skin over the abdomen was normal, ma'am. There was no visible pulsation or peristalsis. Corresponding abdominal quadrants they moved equal on with respiration. Bilateral flanks were free, ma'am. No visible mass noted over the abdomen, and all hernia orifices appeared to be intact, and external genitalia appeared normal. So, coming to
inspection, palpation, yeah.
Coming to the palpation, no local rise of temperature and tenderness was absent. All inspective findings were confirmed, and a solitary mass of size around 11 to 12 centimeter was palpated in the epigastric region, extending 3 centimeter below the gyphoid process, and the lower border was 14 centimeter was felt 14 centimeter below the gyphoid process. Right lateral border 5 centimeter from the midline, and left lateral border was 7 centimeter from the midline. It was oval in shape. The surface over the mass was smooth, margins were well defined, fingers could be insinuated between the mass and the bilateral costal margins. It was firm in consistency, it does not move with respiration, mass was mobile in horizontal direction. On head raising test, mass became less prominent. On knee-elbow position, mass was falling forward. Bilateral flanks were normal. No other mass or organomegaly on palpation. All hernias orifices were intact. External genitalia were normal. And lymph nodes, left clavicular lymph nodes were not palpable. Coming to the percussion, liver dullness felt from right fifth intercostal space in the mid-clavicular line with normal liver span of 12 centimeter. Dull note was heard all over the mass and was distinct from the liver dullness. A band of resonance noted between the liver and the mass. No evidence of free fluid. All other regions of the abdomen had tympanic note. On auscultation, normal bowel sounds were present. Perectal and perivaginal examination were normal. Systemic examination were also within normal limit.
Okay.
Okay, Priyatma, what you suspect now?
Go back to general examination. So nothing positive in general examination.
Yes.
Okay. You know this Karnofsky performance scale?
Yes, sir. They are basically to know about the well-being of a patient who are suffering from cancers. So it is between 0 to 100, sir. I gave a score of 90 because with minimal symptoms, the patient was presenting.
In malignant cancer patients, is it Karnofsky score important or any other score is there?
The ECOG score is there, sir.
What is
European
that ECOG
Committee, European Committee score, sir. It gives from 0 to 5 scoring, sir.
The European Committee.
Committee.
No.
Full expand it. What is that ECOG?
Don't say committee.
No, it's not a committee. It's a ECOG. European Cooperative Oncology
Cooperative
Group.
Oncology, yes.
Okay. So what is it? 0 is what? 5 is what?
0 is a person with cancer who is able to do her own his or her own work without
Zero
any
is normal.
limitations, sir. And yes, sir.
Zero is normal, right?
And 5 is dead, sir.
Okay. Why it is important to know the performance level in
Sir,
malignant patients?
to know the limitations, sir, day-to-day life limitations, sir.
On how it is going to alter the management of the patients in malignancy. Why it is important to know the performance level of the patient?
Post-operative periods, sir, for their recovery.
See, why since this question came ECOG, so what is the basic difference between that Karnofsky and this? So because oncology group patients should receive not just surgery, what else they will receive? What else is treated?
Sir, with their psychological support also they need.
No,
With
no,
that,
no, no.
No, patient optimization before surgery, no?
Yes.
So depending on the
get chemotherapy, radiotherapy, drugs, so many. So whether that is the reason that came out as a separate entity. Okay, ECOG. Karnofsky is quite older one. Yeah, we can go to the next slide. I think.
Sir, there are few questions in chat box with related to examination. Still, you insist the patient to put on knee elbow position?
I think we have not. We are now in the local examination. We'll proceed from here.
Okay.
Correct.
Yeah, we'll start with inspection, then we'll come to that knee elbow position later. That will be better. Yes.
See the where is this? Where are you? I can't see you. What is the difference between you said their abdomen was protuberant, and you said that mass was also that palpable and all that thing.
So I wanted to say that the patient is obese, sir. Like, and with that epigastric fullness was seen.
So if you say the patient was obese with suppose the BMI is high, how do you say it's fullness then? Patient will have protuberant abdomen, then how do you say it's protuberance is obesity? Fullness is something you see.
So the after the like the epigastric was full, sir. Like from the giphisternum, we could see that fullness, sir.
No, Priyatma, in a protuberant abdomen or obese abdomen, it is difficult to make out the fullness in any part of the abdomen because the whole entire abdomen is distended, protuberant.
Yes.
Right. In a flat abdomen or a scaphoid abdomen, if there is any particular region of the abdomen is having fullness or a mass, that can be appreciated.
Share the picture, ma. Share the picture.
So if first time, if anyone sees this abdomen, suppose if I have to say that there is some distension or fullness, you know what I will ask the patient? Only one question. What is that? It is actually distension is what patient complains to you, and protuberance is what it is normal body. Okay, you understand? It's little full. Otherwise, if you say that as no sitting here, we don't know how to describe this. Is it? There's a fullness.
Yes.
The abdominal examination starts with the shape of the abdomen, you know. So, you know, various types of the shape of the abdomen. Can you tell?
Yes. Yes. Flat, distended, and
distended is not a normal shape of the abdomen. It is a pathological abdomen, right? Just now, Shenoy sir told you. So you have an obese abdomen, otherwise called as a protuberant abdomen. Then you have a flat abdomen. You have a scaphoid abdomen. Right? These are the normal shapes of abdomen.
Yes.
Once you say distended abdomen, it is not normal.
Yes.
So only when there is a pathology, you call it a distended abdomen.
Yes.
And in a protuberant abdomen, where you say there is a obesity, and it will be difficult to make out the fullness. They don't go hand in hand, right?
Yes. Yes.
Okay, next point. Epigastric fullness was noted extending to bilateral hypochondrium. Then why do you say it is epigastric fullness if it is extending to hypochondrium? You can say the fullness in the upper abdomen.
Yes. Yes. It was from midline, sir. We could see.
No, but you are telling epigastric fullness was noted extending to bilateral hypochondrium and umbilical.
Yes.
So you can say the entire upper abdomen is having a vague fullness.
Yes.
extending from epigastrium to umbilical region to hypochondric region. Like that, you can explain.
Yes. Okay.
Umbilicus was inverted.
So in this, what exactly she should say, sir? Shenoy sir, can you just...
No, because since we are not seen, better to say upper abdomen is full, that's all.
Yes, yes. Even I agree with sir.
For your information, Dr. Priyatma, what is the smallest quadrant of the abdomen?
Sir?
Very small quadrant of the abdomen, if you divide into 9.
Sir, right and left hypochondriums.
So they are very, very small actually.
Small.
See,
Yes.
these regions, the 9 regions, if you what sir is trying to tell, the hypochondriums, what you see, especially on inspection, is a very, very little, one small triangular area. So
Yes.
the focus is more on the epigastrium and umbilical region. Don't forget that.
Yes.
Okay.
Yes.
Yeah. And if the fullness, if you are not very confident or it is not obviously visible, you don't have to say. You can only say the whole abdomen is distended. The distension is more so in the upper half.
Yes.
For her, if you see from what we see in the picture, the whole upper half looks like a diffusely distended. I don't know how it was in the when you saw, but from the picture, what we see is whole upper half, and there is a demarcation where she ties her sari, probably.
Yes, ma'am.
Isn't it? So that's
I think it should be better to call it as the fullness rather than distension. So distension of abdomen can be uniform distension where the entire abdomen is distended uniformly.
Yes.
Or there can be not uniform distended. There is just a fullness in one particular part of the abdomen, like epigastric fullness or epigastric fullness, something like that. So distension is either uniform distension, or not. So here, if you see the image of the patient, you can see below the umbilicus, it's a normal flat abdomen. Only upper abdomen above the umbilicus is fullness. So I think better to explain it as a fullness in the upper abdomen rather than distension.
Yes.
Okay, proceed, ma. Now, in inspection, one more thing, Shenoy sir, if you noticed, she said external genitalia. In female patients, what pathology in external genitalia will be visible in the abdomen? So understand this. See, it is the male patients where testicular tumors can be missed if you do not examine the external genitalia. Testicular tumors can present as mass abdomen, that is the lymph nodes.
Retroperitoneal.
Yeah. Okay, so you should not miss that. So we say you should always tell even on inspection that external genitalia. But in female patients, the ovaries, the corresponding organs are intra-abdominal.
Yes.
Okay, understand. So don't mention about inspection and palpation. External genitalia. Straight away at the end of examination, you have to talk about per vaginal examination first and then mention per rectal examination.
Yes.
Fine?
Yes.
So, yeah. These are the 2 things on inspection which I thought you should not be mentioning.
Just add that word that all hernial orifices appeared intact. It's better to use the word. I look for
no cough.
No cough impulse.
No cough impulse on inspection.
One more thing, Priyatma.
Yes.
Corresponding abdominal quadrants move equally with respiration you mentioned. I think this is mainly in acute abdomen. When there is acute abdomen, it causes parietal peritoneum, which is inflamed by the inflamed organ touching the parietal peritoneum. And then it causes localized guarding there, and patient tries not to move that particular part of the abdomen. So, movement with respiration is mainly considered in acute abdomen cases, not in chronic cases like this, where there is mass abdomen. It is not ideal to talk about the movement of the quadrants of the abdomen, the respiration.
Okay, palpation.
Dr. Kalaivani, we can add something here?
Yes, sir, please.
See, regarding mass per abdomen, when you are presenting a mass per abdomen for the postgraduates, first you describe the inspection shape of the abdomen.
Yes.
When you describe the shape of the abdomen, you will not get all these questions what they are asking you. Where is protuberant, which is distended abdomen, all those things will not come.
Yes.
And whenever there is a mass, visible mass, you explain according to what are the parts of the abdomen. Finish. That is what.
Yes.
It is a simple one. Understand? Otherwise, you will get a lot of questions there. Why abdomen lower down is abdomen, up to umbilicus is distended. You don't bother all those things. Make it simple.
Yes, sir.
What are the shape of the abdomen?
Sir, flat, scaphoid and protuberant, sir.
No, that question was already asked. She
That's
answered
what
it. I think
you have to make in that way, and you explain where the mass is present and what is that visible. You have to explain it.
Yes.
Yes. Okay.
yes,
This is to
Priyatma.
avoid. You can avoid inviting many other questions. That's what sir is doing
What
here.
Dr. Shafi is trying
Okay.
to tell you is that these are all basic, simple things which are taught to undergraduates.
Yes.
You follow
Okay.
the basic, simple basics, you will not go wrong. So try to follow the basic things correctly. You will be always correct.
Yes.
So don't try to deviate. Okay.
Go to
Priyatma,
palpation,
please,
ma. Sir,
Priyatma, please display the photograph and then describe the palpation. I
palpation.
request all the faculty, if possible, can we take the questions after she finishes the examination?
Yeah, she's finished already, sir. She has already finished
Yeah.
the examination. Any comments on the examination from the other faculty? We should.
Madam,
Yes.
let her do the summary of the examination and then you can take the comments, I think, sir.
Yeah.
Just show the palpation once, Doctor. See, when you
Sir.
mention the lower border, don't mention 14 centimeter away from the zipard process.
Zipper.
Yes.
There is no rule that you should always describe everything in relation to bone, okay?
Yes.
So it's, umbilicus is fairly a good point in the abdomen, okay?
Yes.
So whatever 2 centimeters.
No local rise of temperature you mentioned. The local rise of temperature in the abdomen is not ideal to mention, right?
Yes.
So only
Yes.
tenderness.
Yes.
Yeah, this is one routine thing all PGs are telling. Local rise of temperature. See, that is only for the surface swellings, where you have to rule out any inflammation underneath. Whereas
Yes.
any inflammatory pathology in the abdomen, intra-abdominal inflammation, they'll present with fever, not local rise of temperature, until
Yes.
unless it has protruded through the skin, okay?
Yeah,
Which is
see,
very
see,
too wild
yeah,
an
it's
imagination.
if
That is.
it's an intra-abdominal mass which is inflammatory, still the skin temperature will be normal.
No,
So
Yes.
there is no
okay.
point in telling the skin temperature unless it is a parietal swelling like
So
parietal
don't
wall
mention
abscess.
that.
Yeah, so local rise of temperature is not ideal to mention in a mass per abdomen, chronic abdomen like that.
So just tell the summary of palpation findings so that we'll proceed with the diagnosis.
Next,
Ma'am, we could.
no, next slide. No, madam, just a minute. Next slide.
Yes, sir. Yes, sir.
A few things here. Does not move. The respiration is fine. You said mass is mobile in the horizontal direction.
Horizontal direction.
So
Yes.
in that situation, as Dr. Rajesh Balal has pointed out, yes, books have definitely given that to put a knee elbow, but whenever you have a patient who has got a mobility like this, you can
Hi,
just,
sir, your voice is not heard, sir.
if you turn the patient to one side,
Yes.
rather than putting the patient in the knee elbow position, because
Yes.
Yes.
very, very cumbersome. All that you want to know is the mobility, correct?
Yes. Yes, sir.
In this patient, correct?
Yes.
Shenoy, sir. Sir, voice is not heard, sir. Sorry.
It's
Shenoy, sir.
breaking, sir. Chennai, sir.
Audible? Audible now?
No.
Ah,
Yes, sir.
No, not very clear, sir, please.
Yeah, Priyatma,
Yes, sir.
the knee elbow position is only to differentiate whether it is intraperitoneal or retroperitoneal mass, right?
Retroperitoneal. Yes. Yes.
So nowadays, most of the examiners don't agree for knee elbow position.
Yes.
It is very inconvenient to the patient. They don't do it.
Yes.
If the swelling is intraperitoneal, they say, as Shenoy sir already told, just turn the patient to one lateral side.
Yes.
If it moves, you mark
Yes.
the swelling where it is located before
Yes.
putting the patient in lateral position,
Yes.
and then turn the patient to lateral position. Suppose if the mass is there in the right hypochondrium, turn the
Yes.
patient to left lateral position, and
Yes.
then palpate the mass and mark it, and see the swelling moves.
Yes.
It changes the position. So if it
Yes.
moves in lateral position, that indicates it is free in the peritoneum, but it is not from the retroperitoneum. So this is
Yes.
a better way of examining rather than putting the patient in knee elbow position.
Okay, sir.
Okay.
And another point is when you're saying that this fullness means it is going beyond the abdominal wall, right?
Yes,
So when
ma'am.
you put just in case even if you put, there should be space for the mass to fall forward.
Yes, ma'am.
Okay. When it is
Yes.
already bulging beyond the anterior wall, there is no space to fall forward. First of
Yes.
all, off late, it is accepted if you say, I didn't put the patient in knee elbow. In case, even if you have done, if the mass is protruding beyond the abdominal wall, please don't even mention knee elbow position. It's simple logic. There is no space to fall forward, right?
Okay. Okay.
So a
So
mass,
actually, whenever a mass is moved with the respiration, And when it has got a independent mobility, I
Mobility,
don't think
yes.
it doesn't require again other test to confirm it.
Confirm
Yes.
And it should be done.
Yes, yes.
intraperitoneal mass.
That
Yes.
that definitely confirms that it is intraperitoneal.
Peritoneal. Yes.
Then one more last sentence in this slide. On head raising test, mass becomes less prominent. Is it inspectory finding or palpatory finding?
Sir,
Palpation.
it's an it's an inspectory finding, sir. But on
No, you are in the
because
palpation now.
yes, sir. But in
Palpation, you
on
confirmed, is it?
palpation also, yeah, I confirmed it with palpation also.
So which masses becomes, I mean, less prominent, you are telling?
Yes, like intraperitoneal masses, sir, they become less prominent, and retroperitoneal
Intra-abdominal.
yes. And if they disappear, sir, that means they are retroperitoneal masses.
Okay, this mass is not moving with respiration.
Yes, sir. Like it was not moving with respirations.
Okay. Next slide.
So one or two questions. Am I audible, Dr. Priyatma, now?
Yes, sir.
So we can hear you, sir.
So when you don't have a mass which it is not moving with the respiration, you have to mention also any pulsations felt over the mass. What is the importance of this sentence?
So if pulsations are felt means, first of all, it is arising from the aorta, sir. They can be two types, sir. Either they are transmitted or it is
So in other
pulsatile.
words, anything which is very close to the aorta.
Aorta.
Yes.
So it could be a pseudocyst also will have pulsations, sometimes very close to the aorta. Parietic nodes also. So that has to be come here, okay? And one important thing you should remember that immediately after this completion of the abdomen, don't jump to the left supraclavicular node, okay?
Yes.
You understand? No?
Yes.
You understand? So
yes,
you finish your abdominal examination. You have examined the mass,
yes,
the details you got, and then you have done the rest of the masses, like you are written there. No other mass is felt.
Yes.
What other mass you are interested to palpate now, apart from this mass?
Sir, I wanted to palpate for any other organomegaly, sir, or any lymph nodes.
So what commonly mentioned is the hepatosplenomegaly.
Hepatosplenomegaly, yes.
Commonly. But if you suspect that it could be malignancy, you should look for other details. This is a large epigastric mass. She's 64. So we don't expect that any ovarian masses or something in the lower abdomen. So that's what the answer expected. If the exam will ask you in this patient, the hepatosplenomegaly and any other lower abdominal masses. That's mentioned already, right?
Yes. Yes.
Don't mention organomegaly. All are organs. Intestine is an organ, pancreas is an organ, kidney is an organ. We don't look for all. Only liver and spleen are the systemic organs where they are associated with other diseases. Okay, so we look for these two mainly.
Yes.
Okay.
Priyatma, why did you look for left supraclavicular lymph nodes?
Sir,
what do you suspect? Why did you examine for left supraclavicular lymph nodes?
Sir, in case of CS stomach, sir, they will get metastasized to the left supraclavicular lymph nodes, sir.
Now, do you think it is a carcinoma stomach? Such a big mass, no other symptoms?
No, sir.
You are telling it is not moving with respiration?
Yes, sir. I just wanted to confirm, sir. Like.
Yeah.
No, there is no, history-wise also, there is no hematemesis, melena. And classically, carcinoma stomach patient will have anemia, anorexia, asthenia. Those things are not there.
Yes.
And mass doesn't move with respiration.
Yes.
Still, you suspect carcinoma stomach?
No, sir.
Even if you suspect carcinoma stomach, how it reaches the left supraclavicular lymph nodes? What is the route? How it goes to left supraclavicular lymph node?
So this all stomach, they drain into the cisterna chyli, sir. From there, they drain into the left thoracic duct, and that left thoracic duct they will drain into the lymph node which is present between the left jugular vein and left jugular vein and left
Subclavian.
and
No, where the,
subclavian artery, and that is called as a Virchow's node.
Okay, what is that sign?
Trosier's signs.
So the tumor cells are supposed to be there and they block it, and some tumor cells extra come out of that. So that is what is the one of the pathogenesis behind this, whatever it is. Okay. Yeah.
it's a retrograde spread there.
So,
Okay.
Okay. So next slide. Next.
So diagnosis, are we discussing diagnosis, sir?
Yes, definitely. Yes.
Diagnosis, ma. Tell me diagnosis. What's your first clinical diagnosis?
Ma'am, my first clinical diagnosis is gastrointestinal stromal tumor, which is arising from the stomach, ma'am.
Okay, tell me the points in favor of your diagnosis.
Ma'am, first of all, she was on history-wise, she was not aware of the mass. She was told that it was an incidental finding. Then on history-wise, ma'am, there is no any like anorexia, early satiety, or any obstructive features, ma'am. And on
Do you get
examination,
obstructive symptoms in just stomach?
no, sir, in CS stomach, sir, we get.
CS stomach.
Yes, to rule out. And then on examination wise, ma'am, it was a mass. The surface was smooth, ma'am, and it was not moving with respiration. All the margins were well defined. So it was a.
Priyatma, in these three diagnoses, something is which is seriously not matching with your three diagnoses. What is that physical sign which you said? You said stomach now and omentum.
Yes, sir. If it is a mass arising from stomach, sir, it has to move with respirations.
Yes. I mean, it has to move. It did not move is a little different. But then you said mass is mobile, correct?
Yes, sir. It is a mobile in horizontal direction.
Yeah, it is not infiltrating lesion.
Infiltrating. Yes.
If it is a very advanced carcinoma stomach or large tumor infiltrating the posteriorly, yes. But otherwise, sir, mass you said mobile. Mass has got knee elbow, you said some other finding.
Yes.
Then you said it is not moving with the respiration.
Yes.
Then you are giving three diagnoses based on only stomach.
Yes.
Correct?
Yes.
And 1, 2 are the solid. Can somebody switch out that?
Somebody is talking. Please mute.
Please mute. Martin, can you mute others?
Yes, ma'am. I already muted.
Yeah. Get out. No, it's not muted. Please.
Get out. Please. You get out of my room. You get out. Oh my God.
Can you please mute Martin?
Yes, ma'am. Done.
Okay.
Madam.
Okay. Yeah. Okay. So, see, first of all, when we ask you, you made a diagnosis already as gist of stomach. Now you have to tell all the points in favor of it. Means you have to justify what you have told. Okay. Yes. If you want to really justify, first thing you have to tell is patient's age. Always go in an order, systematic way. First is patient's age. Is the age in favor of gist?
Yes, ma'am.
Yes, 60 to 65, common age for gist. Number one. Then what else is a finding to say, yes, it is gist of stomach. You didn't mention, you gave all the negative things, but you have to tell what is that positive finding which says, yes, this is gist. One is age, which you didn't mention, I mentioned to you. Second point to tell me.
Ma'am, there is no
Sir has already explained. There is no anorexia, asthenia. No, you're telling about the negative points. What is there, you tell?
No, Priyatma, what is happening in your case is you already know the diagnosis that it is a gist arising from the stomach, and you started from the diagnosis and going on. But it's the other way around. You start with the history, analyze the history, examine, and keep your options open without a biased mind. Then see what it is. So your findings are not matching. Like you were telling, it is not moving with respiration. Shenoy sir asked you, can you give any other diagnosis other than stomach, where the firm in consistency, not moving with respiration? So like that, you can think with open mind. Problem here is you already know it is fixed in your mind that it is just arising from stomach. So you are thinking only that.
It can be yes.
See, now that I'll tell you what you should say. Now, since you've already committed, I'm just trying to help you out saying, okay, what are the points? I said age. Number 2, such a huge mass occupying the region of stomach, anatomically the region of stomach, but not causing any compressive symptoms. Patient does not have vomiting, right?
Yes.
If such a huge mass came from inside the stomach or such a huge mass which was compressing on the stomach, they'll have some symptoms. Patient does not have huge mass in the region of stomach, not having compressive symptom will be 1 point in favor of your diagnosis. That is how you have to explain. Anything else in favor now?
Ma'am, on examination, ma'am, it's a surface is smooth, ma'am, and well-defined margins are there, ma'am.
Mobility,
it is mobile in horizontal direction. So it is arising from the stomach.
Can you get above the swelling? Upper part of the swelling is palpable?
It is, yes, upper part of the swelling is palpable, and we could insinuate our finger like towards the both costal margins.
Then it has to move with respiration. There is a place for it to move. And you're telling it is not moving with respiration.
Yes.
So do you think, can you think of any other diagnosis?
Listen. So pseudocyst of pancreas can be there, sir.
Can you think of lymphoma of the stomach?
Sir, but to say lymphoma of the stomach, she should have other features like fever or more than 10% of weight loss or night sweats, sir, or any other swelling.
Those are the B symptoms. Those B symptoms need not be present. Okay, if these are present, then it will add to your diagnosis as B symptoms.
Yes.
If they are not there, that does not rule out lymphoma. So your argument will not stand good here.
I am thinking of primary gastric lymphoma. If
now
it is
you
a
argue.
Secondary gastric lymphoma, you can have these B symptoms. But it's a primary gastric lymphoma.
So there, other than that, the other places also lymph node swelling should be palpable. There is no other swelling any other place of the bodies.
So you should.
How common is it, ma? How common is it? Gastric lymph. Sir has given a diagnosis. How common is it? That is how you should start your argument. How common or how rare?
It's rare, ma'am. It's not common. With that, she should have features of B symptoms should be there, ma'am, to say. It's a lymphoma.
You're committing to
Yes,
that
sir.
again. Please don't come to that. B symptoms need not be present for you to make a diagnosis. You should give other points which goes in favor or against whatever sir is asking. Okay. Now there is a question there in the thing. Is it a pancreatic mass?
Ma'am, to say, we can say it's a pseudocyst of pancreas, ma'am, but she doesn't have any previous history of acute attack of pain, ma'am, acute pancreatitis or any chronic pain or steatorrhea. So that can lead to pseudocyst of pancreas.
Any other finding, your examination finding that is going
not
against
be,
pseudocyst?
Need not
Only
be like
one,
a cystadenoma, like cystadenoma of the pancreas. A large cystadenoma of the pancreas, benign cystadenoma of the pancreas.
Then she should have diabetic symptoms.
No, don't get
No.
confused. In medicine and surgery, there's nothing like she should have. Okay. So just to keep a little bit of this one. So your diagnosis of stromal tumor is, I understand that you know the diagnosis. That is all right. Because we are not there to examine your patient. But such a large mass, you have to defend in the examination. that it first of all, it cannot be carcinoma stomach and omental cyst. Better you rule out that. Okay.
Yes.
You are thinking in terms of stomach with no features of malignancy like loss of appetite and all that has been discussed already. Such a large mass, which is mobile, reasonably health, well preserved, so that the only possibility is the stromal tumors. Only
Yes.
thing we can tell is probably she's so obese. I might have missed the finding of movement with the respiration. We are not here to check. That is one. The second is the pathologic cystadenoma very well matches with your case. They grow more anteriorly. They will not have any backing. They will attain large size. See, you get upper body easily palpable. Correct?
Yes.
Upper body is palpable.
Yes.
Yes or no? Yes.
Yes.
And what is the percussion note? Percussion note?
So,
Percussion note resonance, where did you get?
sir, resonance between the liver margin and the mass, there was a band of resonance was there, so that we could differentiate that it is not arising from the liver.
Liver. Good.
Oh, that is right. So when you have ruled out the liver, when you have ruled out
Intra.
the spleen, and you have only two organs there comes. One is the stomach, another is the pancreas, and go back retroperitoneum. And it is little high to say jejunal tumor. Jejunal tumor is the one which does not move with the respiration. It can have a just also known in the jejunum, can have a mobility, but it will be, like a mesenteric cyst. It will be little lower down. Okay. So this is how we can.
Just to add one more, there can be a tumor arising from the transverse colon, since it is not moving its respiration here. And since it's a very large tumor without any bowel symptoms, so very unlikely to be transverse colon mass. We can keep that also in mind and possibility, but the findings are not in favor because the history is not suggestive. No bowel, altered bowel habits, nothing.
Yes.
So unlikely to be from transverse colon. It's such a big mass. Transverse colon also can have a cyst.
Yes, sir. All the GITs can have, but it is uncommon. And the mobility of the
yes, that's how you should answer. Okay, it is less common. Stomach gist is most common, 60%. So I will consider that first. That is how your argument should come. Okay,
this
good.
is how you should defend in the exams. Like keep all options open. There can be gist from transverse colon also, but why you don't think like that?
So,
you should defend.
First of all, symptoms are not.
No. What you said now only is correct.
Yes.
Just stomach is more common than transverse colon. So I am considering just
in view of your finding that it is not moving with respiration. So another option for this, I said, could be just from the transverse colon because it is not moving with respiration, as you said. So keep that also as an option.
As an option, yes.
Yes. Right?
Okay.
Yes.
Okay. So basically, you should understand if anatomically, if it is arising from the stomach, and if you are thinking malignancy, she does not have any of these symptoms, number one. Number two, and if it is from the lumen of the stomach, patient will definitely have obstructive symptoms for such a huge march. So you must think, okay, probably it's arising from the wall, which is the commonest thing that such huge size at that age occurring from the wall of the stomach, maybe just. This is how you should go in the reverse direction. Okay. Okay.
How do you proceed?
Madam, just to say to Priyatma, commonest things are commonly correct.
Yes.
Talk about common things first, and then talk about uncommon things. And just is more of a histopathological diagnosis. It is more by exclusion diagnosis. It's not by inclusion.
Correct.
So keep this in mind, and I think so we should go ahead. Please go ahead, ma'am.
Yes. Yeah, here I want to tell carcinoma of the stomach, we should not consider here only one.
Yes. Yes.
Because
correct.
Not having any symptoms and signs also.
Yes.
Yeah.
Understood,
ma'am? Let me add something. Whenever there is a mass abdomen, first you try to put it as an anatomical location or diagnosis.
Yes.
What is that? Then you put according to the symptoms, your clinical findings, you put a pathology there.
Yes.
That is the simplest way of otherwise, you will not get all these questions of why colonic mass is not there. All those things will not come.
Yes.
Correct. Correct, sir.
Shall we proceed with the
Investigations?
investigations?
Yes, investigation. Tell me. Keeping so according to your first diagnosis, is just keeping this in mind, how will you proceed?
Ma'am, first we'll go with the basic routine investigations, ma'am, which were normal, ma'am. Then we went with the USG abdomen and
no. You tell what you will do. Don't tell what has been done.
So
you think the case is fresh and you tell how will you investigate.
We'll go with the ultrasonography of abdomen and pelvis, ma'am. That's the basic.
So what will you get to know in ultrasound?
We can get to know from where the lesion is arising, what is the extent, and any
anatomical
position, what is the extent, size, any vascularity, any ascitic fluid, or any other organs, organomegaly. We can get to know. And
don't mention that organomegaly. I just said don't mention
hepatomegaly or splenomegaly.
And ascites.
Okay. Ascitic.
Mainly whether it is a cystic or the solid mass.
Solid.
So that you can proceed with that.
So ultrasound will tell you the anatomical origin of the mass from the anatomical organ. Yes. Okay. Now there is a question. Why not straight away do CT abdomen?
Ma'am, most of the findings we can get through the USG only, and we can get to know the vascularity. And only CT is more helpful if we want to know any meds. In that way, CT is more helpful, ma'am.
You want to do plain CT or contrast CT?
Contrast CT, sir.
CECT.
CECT. How it differs from ultrasound? What extra information you can get in CECT?
So we can get to know the depth of invasion and any meds that are seen better in CECT.
So CECT can detect the metastasis to the liver. It can detect the lymph nodes. It can detect the peritoneal metastasis. So if it is a metastatic disease or confined only to the stomach wall, that can be well delineated by the CT scan. What is the role of biopsy?
Sir, in case of this, biopsy is not advisable. If it is mets or like a recurrence has happened, in that case, we are supposed to take a biopsy, sir.
No, I'm
Otherwise,
asking
it is
percutaneous biopsy. Is it done or not done?
It's not done, sir.
Yes, very good. What about what other types of biopsy? When is the indication for biopsy in this? When do you do biopsy?
Sir, if we are suspecting metastasis or recurrence is there, or if it is inoperable,
whenever there is a ulcer in the stomach, and the gist has ulcerated into the stomach, so do endoscopy and image guided under endoscopic ultrasound. They advise core needle biopsy from the ulcer bed. So ulcer floor, you can take a core needle biopsy to do a immunohistochemistry to prove the diagnosis and also histopathology. So if there is no ulcer in the stomach, usually biopsies are not done. Only in metastatic disease where it is inoperable metastatic disease and the imaging modalities show atypical morphology, then biopsies are advised. So only these two conditions, metastatic disease, atypical morphology in imaging modalities, and there is a ulcer in the ulcer in the stomach, then you can do core needle biopsy.
Okay. CT findings. You have the pictures?
Yes.
If you have the picture, can you put it and read the CT film?
Yes.
You could have put one enlarged. Can you zoom in? Is it possible? And show and one picture you explain where is the mass and what is the extent of the mass. You should have put one picture, ma.
Yes.
So explain.
Still, we all cannot see much.
1 second, ma'am.
Yeah.
So
always know when you make slide, you take a picture of that 1 or 2, sections and put that enlarge zoom in that picture and show. Okay. Okay. Now we cannot ask you any questions in this.
So here.
Yeah, if you can read the CT film, just read it.
Ma'am, here we can see that a solid lesion which is arising from the anterior wall of the abdomen, ma'am. It is just impingement is there, ma'am, and posterior wall of the abdomen is free. Here, here we
Oh,
can
okay,
see
okay.
more.
Correct. When we zoom in, we can see. You can see the lumen. It's
Yes, ma'am. It is patent.
okay.
The lumen
It's
is
lumen
patent.
is patent,
Here.
coming
Is
from
it
the anterior wall.
Just
is
one
it
minute.
is it
Priyatma, what did you tell? Posterior abdominal wall. What did you tell?
No, sir. Posterior stomach. Sorry, stomach walls. Stomach walls.
posterior wall of the stomach, you mean?
Stomach. Yes.
So don't get confused now, okay? Because I was also can't see it
Yes.
properly. So
Yes.
what? So tell me one important thing that these are common in the stomach. Which part of the stomach? Are they more for distal or proximal?
Sir, they are more common in the at the body, sir. Like at the proximal
At the
body.
greater
Body, they are
curvature.
more greater
Along the
curvature.
greater curvature.
Greater curvature.
So along the greater curvature, more towards the proximal side.
Proximal.
Not the distal side. Okay.
Yes.
So what is your finding? And you already told that lumen is narrowed, correct?
Yes.
Any air shadow is there inside the tumor? Difficult for us to see here, but why did I ask that question? If there's an ulceration in the mucosa there, gastric mucosa, you'll be able to get a air shadow inside.
Air shadow.
Yes.
Classical. In fact,
It is not. It is not there.
You also find out and look for the necrosis in the tumor. So that is very important to predict the prognosis. So high grade cyst and the wild type cyst will have a lot of necrosis in the CT.
Yes.
That is also one of the important finding. If there is evidence of necrosis in the tumor, so it is having a very bad prognosis.
Yes.
Okay, what next, ma? What next you want to do? Now a CT scan is showing mass arising from the anterior wall of the stomach.
Yes.
And according to you, there are no metastasis in the liver, no peritoneal metastasis, right?
Yes, ma'am.
Fine. So what will you plan to do next?
What is the size of the tumor? What is the size of the tumor?
So it is 11 into 12 into 10 into 9 centimeters.
Okay, almost 13 centimeter.
Yes.
Keep that in your mind.
Yes. So it comes as a high risk, sir. So we have to do wide local excision, surgical intervention.
Surgical intervention. But you're still not sure it's just only, right?
Yes, ma'am.
Okay, you go ahead.
So we'll go for surgical intervention.
No,
and,
any other investigations you want to do?
We'll
Confirm.
tumor markers, we can say.
No, apart from UVS, if it is there, you can go for UVS so that you can see the which
upper
layer.
GI, yes.
You put the picture, but you're not explaining.
Upper GI endoscopy was done, ma'am. In that, we can see the lumen was patent, ma'am, and there was no ulcers over the mucosa, ma'am.
Any indentation is there?
Indentation was also not there, sir.
So if you want to be very, very sure that you want to take a biopsy now, short of that endoscopic, any other imaging modality, if it is there, can you do it? Endoscopic?
Ultrasound guided.
Just complete. Yeah, yes.
Ultrasound guided endoscopy.
So if it
First of all, endoscopic ultrasound.
Ultrasound, yes.
Endoscopic ultrasound guided core needle biopsy.
Core needle biopsy.
Yeah.
So otherwise, indentation is there in that area. We can always, the suspected area, you take a biopsy, that you get only mucosa. Then you get a deeper one, that's called a biopsy on a biopsy, or a deep biopsy, or a core biopsy, or a well biopsy, something like that. That some nomenclatures are used. Okay. Yes.
Well and a well, they say.
Yes.
So now, next, what you want to do now?
So how do you confirm, apart from histopathology, if you send it for immunohistochemistry, ISC,
yes.
What do you expect to confirm your GIST diagnosis?
Sir, we'll send for CD117 and DOG1 and CD34 also, sir. They have to be positive.
There is a KIT mutation and there is a
KIT mutation.
PDGFRA mutation.
Yes.
Right. In 90% of the GIST, they'll have either a c-KIT mutation, which will have
PDGFRA.
CD117 and PDGFRA. What is PDGFRA?
Platelet-derived growth factors.
Platelet-derived growth factor receptor alpha.
Yes.
Okay. So if both are negative, CD117, that is c-KIT mutation, and PDGFRA negative, what next? That is called as wild GIST.
Wild type GIST, sir. Then in that case, 10%. We can say send Desmin or
Desmin is to rule out other sarcomas, yes. Like to differentiate GIST from other sarcomas, like leiomyosarcomas, right?
Yes. Yes.
So if you are not able to differentiate between sarcomas and GIST, so Desmin will be positive in other sarcomas like leiomyosarcomas.
Yes.
So to make a diagnosis of GIST, wild GIST, other than sarcoma, what other investigations you would like to? When c-KIT and PDGFRA are negative, any other investigation?
Okay, will immunize? Okay, you are going to answer sir's question. Anything else?
Any role of PET scan here?
PET scan, it can tell about the like after like mets, distant mets to the liver.
That CT only will tell, ma.
Yes.
Okay. So here now, will this immunohistochemistry help you in any kind of plan of your treatment?
Immunohistochemistry is still awaited, ma'am.
Okay, now we are talking about the preoperative. Sir, we all just now discussed about endoscopy, endoscopic ultrasound, and biopsy. In case you have done a preoperative immunohistochemistry, such a huge tumor, it's more than 10 centimeter. Will it help you in any way in treatment of the patient?
Yes, ma'am. We have to, because it's a more than 10 centimeter and immunohistochemistry has come positive, we have to start with tyrosine kinase inhibitors, ma'am. Adjuvant therapy.
So that can...
That is not called adjuvant therapy. It is called neoadjuvant therapy.
Neoadjuvant therapy.
Right? It's a very large tumor of more than 10 centimeters.
Yes.
You have very high mitotic figures. Or if the tumor is unresectable, clinically it is unresectable, where you cannot give arterial resection.
Yes.
In such cases, you start a neoadjuvant therapy with imatinib, and it is continued for 3 to 6 months. So especially in metastatic disease, unresectable lesion in the stomach, okay, with a very large tumor, then you start a neoadjuvant therapy. Minimum, they say, it should be given for 6 months and see the response. And then if the tumor regresses in size, it becomes resectable, operable, then you can go ahead and do surgery.
So here we have a patient where you have not done a biopsy and it's a huge mobile mass. So what will be your plan of action?
Ma'am, we after upper GI endoscopy, all confirmation, we'll go for a surgical resection, ma'am. Wide local excision with a 2 centimeter margin, ma'am.
Okay. And you'll send
for HPR. And with that histopathology we'll send with that IHC marker, immunohistochemistry.
Okay. What are the prognostic markers for a GIST?
Ma'am, prognostic markers, they are 3 things are there, ma'am. First, where it is located. Second thing is what is the size of the tumor and mitotic index. 3 things. Like depending on that, we divide in low, intermediate, and high risk, ma'am. If it is low, less than 2 centimeter with 5 to 50 high powered field, it is low risk, ma'am. Then more than 2 and less than 5, ma'am. With 5 to 50 high powered field is intermediate, and high risk is more than 5 and less than 10 with more than 5 to 50 high powered field, and more than 10 centimeter and more than 5 per 50 high powered field are high risk.
Now, this patient is high risk or low risk?
This patient is high risk, ma'am, because tumor size is more than 10
Size
centimeters.
itself, isn't it? Okay.
Yes.
Okay.
So this
So,
risk stratification, what you said, it applies to stomach or gastric just only. This varies
Yes, sir.
from other.
It varies.
Suppose,
Esophagus,
yeah,
it is different.
yes, for a colon it is different. For
Different,
esophagus
yes.
it is different. For esophagus, just in the esophagus, 2 centimeter itself is a high
Is
risk.
a yes.
Okay.
so
You should know
Shenoy,
that.
sir.
Yeah, nothing. What Priyatma, what you should tell is that if in the examination, at least point of view, start with the ultrasound, then CT scan, and a PET scan. I think not that you should not do. You can always do, but reserve it for a follow up of the patient, especially when you want to assess them. That is one thing. This is the, of course, the very large tumor. Definitely, everywhere PET scan will be done. Not that it is not done. Number one. And second thing is, don't say wide excision, correct, but best is the en bloc, en bloc dissection. That entire tumor, especially this is more proximal lesions known to infiltrate even the diaphragm. So all that en bloc, including the lymph nodes, everything you have to remove. But in spite of such large size, invariably we are able to save the stomach very often. Because if you own that picture nicely, it will have one area which is so it is possible to save. That is what is the idea. Then followed by such a large tumors, what is the drug which you use now?
Imatinib, sir.
Imatinib.
Imatinib mesylate.
Any
Tyrosine.
yeah, dose and any duration.
400 mg OD, sir, for 6 months, sir. And if if we are using as a neoadjuvant and size is not decreasing, we can make it to 800 mg OD, sir.
So that is why that is some criteria they have described. Do you know any something like a RESIST criteria mentioned for a sarcomas? Sarcoma, soft tissue sarcoma. So that's a response evaluation basically. RE is nothing but a response in a solid tumors. In solid tumor, that is how it is. So similarly, like breast, we have say like complete response, partial response, no response, stable disease. So in the same way, this gist also should be followed up. Okay. Yes.
So Dr. Venkatachala has commented in that if there are liver metastases, it's an indication for PET CT.
Yes. Definitely.
Okay. Dr. Venkatachala could add some points.
Hello.
Yes. Dr. Venkatachala, please.
See, most of the gastrointestinal stromal tumors, they arise from organs which are draining by the portal venous system. So invariably it is like in a colorectal cancer, in a colon cancer particularly, or a gastric cancer, we don't do PET CT because we know that first it has to spread to the liver. Even if there are peritoneal disease also, it has to go to the liver and then it can go to the rest of the body. So the only other place we can suspect is the lungs. So HRCT of the thorax can be useful. So routinely we are not doing PET CT in just tumors. Definitely, if there is already the disease has spread or if there are liver metastasis, we would like to know the next level of metastasis.
So you understand the indication?
The only thing why we say against PET CT is only when indicated radiation from CT scan of the whole abdomen itself is around 1200 millirads. Radiation from PET scan is another 1000 millirads. So that is a clinically significant radiation exposure. Many of the patients, if you are doing PET scan once in 3-4 months, they may live for 10 years, 15 years to develop hematological malignancies.
Yes.
So we have to use everything judicious.
So you understood the indication for PET CT?
Yes.
So if these should first drain into the liver, so if this is present, then only PET CT. Very nicely explained by Dr. Venkatachala.
Priyatma, what are the toxicity of imatinib? How long you give imatinib? What is the toxicity?
Sir, for 3 years, we can give, sir. Neutropenia, neutropenia will be there.
The
We
main
say as long as
problem
the patient tolerates, the patient still develops a toxicity on giving.
The main problem here you have to understand is that one is that there will be a lot of cutaneous reactions with these tyrosine kinase inhibitors or any of the targeted therapies because they react with the epidermal growth factor proteins, skin proteins. So there will be blisters, There will be rashes, there will be peeling of skin, there will be desquamation. That is a dose limiting toxicity. Alternatively, you will also have to look for the blood counts. If these are the patient is tolerating well, you can continue as long as the disease responds and as long as there is no progression. If there is measurable disease, many times they will progress after few months. Unfortunately, we don't have this platelet-derived growth factor receptor study easily available all around India. If they are not responding to imatinib, then we'll have to think of other alternative drugs like dasatinib, etc. Or you will have to also consider for PDGF for receptor analysis. Many times we have to send to outside India, so it is not available here. So it becomes very difficult. If surgery is possible whenever during the treatment, if whenever as early as possible when surgery is possible, please go and do the cytoreductive surgery. That is the best way to help the patient.
Reduce the tumor burden. Okay. What exactly was done here, Priyatma, for this patient? It was involving the entire anterior wall?
No, ma'am, it was just attached to the lesser curvature. Lesser curvature.
So wide excision and primary.
Wide excision with 2 centimeter margin, ma'am. It was excised, and then the layers were closed in 2 layers.
Stomach edges were closed.
Stomach, yes, in 2 layers.
Okay. Okay.
This specimen looks like I can see the umbilicus there, correct? No?
Yes.
And what is this incision and how you have brought it out? Like what I'm not getting the orientation.
Sir, upper midline incision was taken, sir, from like episternum till the umbilicus, sir. And then we could see a firm mass with irregular surface, and it was arising from the lesser curvature, sir. And it was just
kind of
avoiding the
pedunculated.
inferior surface. Yes, pedunculated.
Yeah.
Inferior surface of the left lower of the liver.
The specimen doesn't show any stomach wall there.
Yes. Here, sir, in the third picture, we can see.
Stomach wall is seen.
Yeah, there are some dilated vessels on the anterior wall of the stomach. We can see there where the incision is there, no? Little bit this side. You can, if you enlarge the first picture, enlarge. You could probably, no problem. Yes. To put your cursor on the near the incision side, not on the specimen side. Little down there, you can see the vessels there. You see, they're typical stomach vessels.
Yes.
Greater curvature or along the greater curvature.
Yes.
You can see that. Okay, no problem. Yes.
You started the patient with imatinib post-operatively?
So we are still waiting for the IHC.
Histopathology report has come?
Yes, sir. It is awaited, sir.
Still that is also. Okay. Shenoy sir, anything?
Madam and Rajgopal sir, can we summarize and tell them how to go about this case? Yeah. And so that as we are running out of time also, we are overshot by half an hour actually, sir.
So as a whole, Dr. Priyatma, you have done well. Number one, congratulations. You have come forward to present in a good forum. When you started your 64, your last, it was 64 in our candidates have come. Now I think 1995 have attended this meeting, number one. Secondly, epigastric mass and the dull aching pain. That's where you were fumbled a little bit. Okay.
Yes.
Don't make cholecystitis, gastritis unwanted. So dull aching pain, epigastric mass. So that's how we start with. So we know very well that why this patient had dull aching pain. There was no luminal obstruction. This is such a large mass that itself gave a dull aching pain.
Yes.
Epigastric mass. That is the reason. Because we are so much. We generally say it's a solid organ, but this is how it is. So you have to discuss in that direction, pain and the mass. Then the problem was with the omental cyst. That should have never come into the discussion here.
Yes.
Giving carcinoma stomach, okay, roll out, because thinking that a most common cause is epigastrium is carcinoma stomach as per the is concerned. Still, we know that it is not carcinoma stomach in the bottom of the heart. Every one of us know. So, put out liver because it is not from the liver. So, then start with if it is a stomach, what 1 or 2? Okay.
Yes.
Nowadays, we are accepting the gist. When I was a PG, it was that entity was not there. It was some leiomyosarcoma and all. So today, all examiners will accept an epigastric large mass. One could be a Castro. Apart from the stomach, what else you think if it is asked? It is stomal tumors. Then pancreas, one or two things should be kept in mind. When you suspected a solid tumor like this, don't bring momentosis. Okay? And nearby test, I think has been already pointed out, so much cumbersome, so lateral position is better. All right? And investigations have been sorted out. That's my comments. Well done, Dr. Priyatma.
Thank you, sir.
Kalaivani madam, unmute and talk, madam.
Just as a diagnosis after ruling out other conditions. Basically, it's an exclusion diagnosis. Dr. Narayan mentioned this in the beginning itself. Fine. Sir has concluded, Chandru, it's all fine now. Any comments from others, and you can go ahead.
Only one suggestion from my side is that, when a large mass like this in the epigastrium without any symptoms like this in this patient, so none of the anorexia, anemia, asthenia, nothing was there, no hematemesis, no, totally asymptomatic, but for the mass and mild pain. So in such cases, always think, as Shenoy sir already told, like stomal tumors.
Yes.
Okay, little more you read up about examination of abdomen, mass abdomen and chronic abdomen. These two chapters you please read from Das.
Yes.
In detail, including the differential diagnosis given in mass abdomen.
That is a homework for you.
Yes.
Madam, Das and Das only.
Das, clinical methods, manual of Das is the,
Bible.
the book for us. Yes.
Sir, Chairman sir, with your permission, if there are no more questions, we'll conclude this session.
Yes,
yeah,
Chandru.
Please present the vote of thanks.
Thank you for the opportunity,
KSCASI,
President and Secretary.
We'll thank the faculty, Dr. Srikanth, Dr. Kalaivani Madam, and Dr. Rajgopal Shenoy sir for an excellent discussion. And also I thank Ramakanth sir for moderating, and today's hero is Dr. Priyatmakumari. An excellent presentation. Definitely you have done justice to your presentation. It's all learning process where you learn and we learn in this process of clinical discussion. And I also thank all the members of KSCASI who are present today, both national and state executive committee members, and our National Academic Council chairman, Dr. Uday sir, and all the postgraduates who took active participation. And we have more than, I think, 50 or 60 questions in the chat box. There was a lot of discussion going on the chat box also. And to surprise, we have more than 100 attendants both on Zoom and as well as on YouTube Live. Thank you everyone for making this a grand success. Thank you very much.
Thank you for giving the opportunity. Thank you, Chandru, and
thank you, madam. Thank you, sir. Thank you,
Dr. Ramakanth sir.
Thank you, sir. Thank you, madam.
Thank you, one and all. Good night.
Excellent job. You were a good punching bag. Everybody punched on you, but still you withstood everything.